pleasure for me to be here in the city of Jodhpur.
I am here after a long time. Last time came was when the IFS annual conference was there. My talk is explaining the unexplained infertility. Let us look at the definition of infertility. It is affecting 10 to 15% of the population. In India, almost 23% of the population is affected by infertility. That translates to almost 27 million couples. This is the old figure, 12 to 18 million. Now it's around 27 million. And generally, it is failure of a couple to achieve clinical pregnancy after 12 months of more or regular unprotected sexual intercourse. That is a definition of infertility. What we are going to talk about is unexplained infertility. It affects almost 30% of infertile heterosexual couple who are the diagnosis of unexplained infertility is based on the diagnosis of exclusion. That is, in the absence of abnormalities of female and male reproductive system after standard investigation. The SMART definition of unexplained infertility is in couples with apparently normal ovarian function, fallopian tube, uterus, cervix and pelvis with adequate coital frequency and apparently normal testicular function, genitourinary anatomy and normal ejaculate. So applying this definition, you need a male and a female gamete. Hence, this unexplained infertility is only in heterosexual couples. The question is, after how many months unprotected intercourse is defined as infertile? The wide range of data, 237 studies about unexplained infertility, 87 related to the time of unprotected intercourse to almost 1 year, 46.1%, 39% reported in 2 years. Overall, 25 to 30% couple face unexplained infertility. The SMART definition only refers to clinical diagnosis without any reference to the duration of unprotected intercourse or female partner age, which is also important. And it has been defined that female partner age is defined as age of 40 or less. And there was mathematical model showing that after 2 years of regular intercourse, the false positive diagnosis of unexplained infertility is 10% in women under 35, and it increases to almost 80% in women over 40. So women age is very important. Unexplained infertility is a very frustrating diagnosis. Patients say there is no cause for the infertility and hence no effective treatment. No. There is a management of unexplained infertility. Couples want a baby, but they don't want an exhaustive and prolonged investigation. Unexplained male infertility, it is almost in 15% of the patient. And what is required is exhaustive recording of patient medical history, physical examination. Just need a complete semen analysis as per the latest WHO 2021 criteria. We don't need anti-sperm antibodies, we don't need microbiology testing semen culture, or we don't need sperm DNA fragmentation. I again want to repeat it, when you want to diagnose unexplained infertility, we don't need anti-sperm antibodies, we don't need microbiology testing of the semen or sperm DNA. This is from the latest guidelines on 24. These all tests are not needed for diagnosing unexplained infertility. WHO manual, all of us know, 2021. What is the definition? This is 15 million and the mortality has to be 39% or more and morphology 4%. In this mortality, what has mattered is that they are classified as per the 4th edition, and we are going back to the 4th edition because this gives us additional prognostical information. We are classified in 4 categories: Class A, Class B, Class C, Class D, and the total mortality has to be 42% combining Class A, B and C. The low reference value of total mortality is 42%. Why it is important? Based on the existing literature, progressive mortality is the only important sperm parameter in predicting the likelihood of pregnancy via natural contact, natural coitus. The new guidelines for unexplained infertility, the European Association of Urology in 24, they had recommended doing a whole genome sequencing in men with unexplained infertility in cases of genetic variant affecting spermatogenesis, meiosis, chromatin remodeling, sperm motility, and key genetic panel Y chromosome model karyotyping and cystic fibrosis. These are all the genetic guidelines, but basically exome sequencing is what is being advised by the European Urologic Association. The genetic normally affect almost 10 to 15% of infertility cases, and you have to do as per the indication. If a non-obstructive azoospermia, you do karyotyping. Obstructive azoospermia, you do cystic fibrosis plus exome testing. If you look at azoospermia, multiple morphological abnormalities of huge sperm flagella, astenospermia, all these cases need exome analysis, which we have to learn now. Unexplained female infertility. You have a good preconception practice of checking for BMI and thyroid TSH. You have to confirm the ovulation. If it is a regular menstrual cycle, otherwise you can do a LH kit or mid-luteal progesterone or ultrasound monitoring. You have to check for lutein factor by doing 3D ultrasound, and you have to check the tubal factor by doing hypoxia or SCG or tubal patency. Other unusual causes of unexplained infertility. Well, we all know what is the window of implantation. Date 19, day 21, when the implantation is likely to occur, but when it's failed, there might be subclinical endometrial dysfunction. And this subclinical endometrial dysfunction can be because of the microRNA. MicroRNA 124-3P, this is a microRNA. It can inhibit the critical genes, and in cases of unexplained infertility, the endometrial microRNA expression may emerge as a diagnostic adjunct in patients with unexplained infertility. So, in the future, we might be doing ERA test, and we are going to test for microRNA panel also in the ERA to see about the subclinical endometrial dysfunction. The immunoprofile, among the patients with immunological infertility, the level of various T follicular helper cells, IL-21, they can correlate with presence of autoantibodies, and detection quantification of T cell, IL-21, IL-12, and TNF alpha may provide you diagnostic indication. Management of infertility, unexplained infertility. We had this review published in 2018, and in this they say couple with unexplained infertility, a progressive become pregnant without assistance in the next 12 months is estimated as per Hanald score. Hanald score, depends upon the woman age, the duration of infertility, the type of subfertility, whether primary or secondary, the sperm progressive motility, and from where the patient has been referred, whether from secondary care or tertiary care. So you have a calculated score, but the problem is that this is a 20-year-old Hanald scoring. At that time, there were no AMH available to us. There were no AFC. There were no endometrial receptivity or lifestyle factor. So this is basically based on Caucasian population and with very limited generality. But this is the only score we have got now, which we are using in our practice. Another publication in 2018 by Donoff, he gave for unexplained infertility either stimulated with gonadotropin or stimulated with clomiphene. Because there is a lot of discussion whether you have to stimulate the patient with gonadotropin or you have to stimulate with letrozole or clomiphene. There have been reports earlier that stimulating with gonadotropin is better. As per this report, it all depends on the counseling of the patient, the cost and patient preference has to be taken into account. It doesn't make any difference whether you stimulate with gonadotropin, with clomiphene or letrozole. You have to take the cost and patient preference into account. Other prognostic model which we have in future is the artificial intelligence based scoring system, and these models will consider endometrial receptivity, embryo quality and immune profiling of the patient, and this will help us in patient counseling, prioritizing cost effective timely intervention, expectation management and personalized treatment. This is what we are going to see in future. According to the latest guideline in 24, which were published by Australian Society, they have taken the efficacy, safety, cost and risk of treatment option have not been subjected to robust evaluation in the previous guidelines. Like we had a Canadian fertility guideline in 2019 and we had American Society of Reproductive Medicine guideline in 2020. But both these guidelines did not include a data integrity check they didn't use the great framework of formulating the guidelines. So that is why ASHRAE came up with another guideline in 2023, which was a very robust guideline. And the ASHRAE people, the Australian people are just modified that ASHRAE guidelines to the Australian context. So evidence-based guideline unexplained using adopt process has been approved by the Australian National Board. What are the changes between the Australian guidelines and the previous guideline? That is, the recommendation is based on the grade framework, and there is established data integrity. According to this guidelines, they have added practice points, they have added research recommendation. All this has been added in the new guideline. The criteria is evidence-based recommendation, or it is practice point, which is where evidence is not sought, or there is insufficient evidence to make it an evidence-based recommendation. There are 40 evidence-based recommendation, 21 practice point, and 3 research recommendation. They are addressing the definition, diagnosis, and treatment. The grading of the recommendation is conditional against the option, conditional for either option, conditional recommended for the opinion, and strong recommendation. The strength of evidence is high, low, moderate, low, very low. All the meta-analysis, systematic analysis are high recommendation, and randomized controlled trial is moderate to low recommendation. Now we come to the finally this guidelines. From this 24 Australian guidelines, they have defined the definition 12 months of regular unprotected intercourse, and defining the intercourse, frequency of intercourse at least every 2 to 3 days during the fertile window. Female age is important, although male age is less significant, and a regular menstrual cycle is considered between 21 to 35 days. Confirmation of ovulation in regular cycle, test for confirmation of ovulation not routinely recommended. You can do a LH serum, urine LH kit, or ultrasound monitoring. Oocyte and corpus luteum quality is not routinely measured. Ovarian reserve test is not done. Tubal factor is hypoxia or HSG can be done, and they are comparable in diagnostic capacity. Chlamydia antibody testing is done in cases of when there is a high risk of tubal occlusion. Uterine factor 3D ultrasound is enough. Laparoscopy is not recommended. If you look at the right side, there is a strength of the recommendation that an evidence-based recommendation is against. So all these are against they are not to be recommended. Cervico-vaginal factor, post-coital test is not recommended. So all these are against. The male genital urinary anatomy, all recommendations are against. You don't have to do it. You don't do testicular anti-sperm antibody, DNA fragmentation, or sperm aneuploidy, serum hormonal testing. Don't have to do any of the tests. Additional testing for anti-sperm antibody is against. All of them are against. Thyroid evaluation is recommended. If TSH is within normal range, there is no underlying history. You can do only the TSH. That is preconception. Expectant management, IUI with ovarian stimulation can be considered a first line of treatment. It is advised to base the decision to start active treatment of prognosis in couple with unexplained infertility. IUI with ovarian stimulation can be recommended a first line of treatment. And to avoid multiple pregnancy, ovarian stimulation, there is needed to use the gonadotropin treatment only in low dose regime. So we don't use gonadotropin as a first choice because we are worried about multiple pregnancies. Healthcare professionals should be aware there is a probability of no difference in quality of life. I'm just finishing. This is the algorithm for treatment. If it is a good prognosis, you expectant management for 6 months. Then if the patient doesn't become pregnant, then go for active treatment. Consider IUI with ovarian stimulation. Or if there is no pregnancy, then consider IVF. So that is the last option. IUI is performed in a specialist clinic. It is not done in a gynecologist clinic. It has to be done in a specialist clinic because several cycles of IUI can be as effective as IVF, and this may prove more acceptable to patient and more readily applicable to regional center which lack sophisticated embryology laboratory. You don't need a sophisticated laboratory for IUI. We need further research, quality research in this field, and key is to able to accurately advise couples and major priority across stakeholders moving forwards. Take-home message: principal treatment for unexplained include expectant observation with limited intercourse and lifestyle changes. Colombia State, IUI, control ovarian hyperstillation, and IVF. This is the line of management. Female age is important. Female age more than 38 should be counseled for IVF sooner rather than later. Unexplained infertility, you have to think IVF is a treatment of choice, but when the less costly treatment has failed, when IUI has failed, only then you go for IVF. Thank you very much.
Sir, it was a wonderful talk, and I think very, very informative for the audience as well. Even I learnt a lot. So just to summarize the practical points, the first thing is too much of testing is not required. Like trying to find out the reasons for unexplained infertility is not so important, rather to understanding what are the management recommendations given by the authorities after all the research work already done. So too much of DFI testing and laparoscopies and microbiological tests, all that is not that much required. First is that. Endoscopy one has to individualize, but if we see a beautiful triple layer, good 8-9 mm endometrium on a 2D scan mid-cycle, a good HSG and no other clinical relevant history, then probably a laparoscopy is not recommended. You can directly move on to IUIs or expected treatment in very good prognosis cases maybe, but practically we are not doing that. IUIs are to be done only where you are using some form of ovarian stimulation, either clomiphene or low doses of gonadotropins. So only oral ovulogens are also not recommended without IUI. So for unexplained infertility, we have seen that many of our friends, they would keep on giving many cycles of letrozole or clomiphene. Even that is not going to add much significantly in live birth rates and pregnancy rates. So it has to be ovarian stimulation with IUI, maybe 3-4 cycles, and then move on to IVF. So thank you so much, sir, for this elaborative talk.
Thank you. You see, it is the fourth guideline. So we have to accept all the changes, which I have been also practicing, but I have to do changes in my practice, how to identify the unexplained infertility.
The patient would ask you, you are recommending an IUI, but isn't there a possibility that now we can conceive naturally? And then you have to tell them that there is the possibility, but it's all a game of probability. So the probability is now going low and we have to bring it up, and maybe that's why the role of recommendations do come. Thank you.
Thank you, ma'am.
Thank you so much, sir.